In this third part, I would like to briefly discuss inflammatory and autoimmune disorders that may involve the Sellar, the Pituitary, and the paracellular region. I would like to concentrate on those disorders that may show some predilection for involvement of the infundibulum, pituitary gland, or hypothalamus. Many pathologies may involve secondarily the skull base, but we're going to concentrate on those that may have some imaging features that could be that could show some predilection to this area. Starting with neurosarcoid. Neurosarcoid is a disease of unknown etiology. It is its hallmark is granulomatous inflammation. These patients have non-caseating granulomas, and they can occur virtually anywhere. It's a disease that we see most commonly in females. There is a bimodal age distribution in young females, and then later after 50 years of age. About 5 to 15% of patients have clinical CNS involvement. If you look at autopsy data, the percentage is much larger, up to 27–30% of patients can have some evidence of CNS involvement. But when we talk about clinical CNS involvement, we say about 15% of patients can have it. And almost all of these patients who present with neurosarcoidosis will have some evidence of disease in the chest. And we say that 90% of patients would have evidence of lymphadenopathy on chest radiograph, but rarely we can see primarily CNS isolated neurosarcoidosis. Half of the patients are asymptomatic, but patients can present with complications. You can see hydrocephalus that can be communicating or non-communicating depending on when the lesion or where the lesion is located. Vasculitis, you have an inflammatory process, granulomatous inflammation. You can have ischemic changes depending on which vessels are involved, and patients can present with seizures. You can have a leptomeningitis, a granulomatous leptomeningitis. So the complications are going to present depending on the location of the lesion within the central nervous system. About 1/3 of patients can have leptomeningeal disease. This is an axial post-contrast T1 weighted image where we can see evidence of leptomeningeal enhancement on the falx and along the surface of the cerebrum. And we also have parenchymal lesions on the left side. We know that 1/3 of patients approximately have multiple parenchymal lesions. This is the same patient coronal images post-contrast where we can see some of that leptomeningeal enhancement. We also see parenchymal masses bilaterally that extend to the lateral ventricles, and we see some evidence of ependymal enhancement on the right side. And note also that in this patient, the lateral ventricles are dilated bilaterally. And about 10% of patients can present with solitary parenchymal masses, in which cases it can be confused with a different pathology. About 10% of patients can have a predilection for sarcoidosis in the hypothalamus or infundibulum. It can affect the optic chiasm, and this is known to be one of the favorite sites for neurosarcoidosis, although it is not entirely specific because other entities can present like this. It is one of the known locations. For neurosarcoid, this is a case of a patient with neurosarcoidosis, axial post-contrast T1 weighted image. We see an avidly enhancing mass in the suprasellar region displaying the optic radiations. On the axial T2 image, we see that the mass is dark, relatively dark on T2 image, which is fairly characteristic. And it's something that you can see in granulomatous processes. So it is not specific to sarcoidosis, but basically any granulomatous process in the brain and in other areas of the head and neck can look dark on T2 weighted images. And other entities such as Langerhans cell histiocytosis that we're going to briefly discuss later can also look dark on T2 weighted images. So it is not specific, but it is one of the characteristics that we have described with neurosarcoidosis. And a minority of patients can present with a primarily extraaxial dural-based mass. But again, let's remember that sarcoidosis can occur anywhere and affect any tissue, soft tissues, bone, cerebral parenchyma, and peripheral nerves. So patients can also have neuropathies. Different patient with neurosarcoidosis, we have an axial post-contrast T1 weighted image, and we see enhancing nodules in the suprasellar region. On the coronal images, we see the nodules around the infundibulum and hypothalamus with avid enhancement. On the sagittal image, we have one of the classic appearance for neurosarcoid involving the hypothalamus. If we remember the anatomy of the third ventricle and we look for the presence of the normal suprachiasmatic and the infundibular recess, we see that those two are obliterated here because of the presence of enhancing tissue. So enhancement is usually avid, and one of the things to look for is absence or obliteration of the recesses of the anterior third ventricle. And the other thing in every pituitary case is evaluation of the infundibulum that should taper as it goes inferiorly to join the pituitary gland. And in this patient, we also see a lesion in the right medulla that is parenchymal and is avidly enhancing. So neurosarcoidosis can occur anywhere. And one of those areas of involvement can be the suprasellar and sellar regions and hypothalamus. Another presentation that has been described with neurosarcoidosis because of its propensity for perivascular spread is enhancement along the perivascular spaces. This is a different patient with neurosarcoidosis. We have 3 axial post-contrast T1 weighted images where we can see extensive enhancement, sometimes with areas of nodularity along the perivascular spaces. So this is another known distribution or presentation of neurosarcoidosis, although it is not as common as the other distributions that we just discussed. Hypophysitis, very non-specific appearance. We have multiple etiologies for hypophysitis. You can have idiopathic hypophysitis, autoimmune inflammatory, primary lymphocytic hypophysitis. We see hypophysitis during pregnancy, after pregnancy, but there's also different secondary causes of hypophysitis. We talked about granulomatous inflammation, sarcoidosis, Wegener's inflammation can also result in hypophysitis. There's drugs that have been implicated with hypophysitis. One of the better known, relatively recent drugs is ipilimumab, which is a monoclonal antibody that can result in hypophysitis as well. And IgG4 related disease, usually when we see hypophysitis related to IgG4, it is in patients who have systemic disease and involvement of multiple organs. And for the most part, findings are non-specific, and they're going to look the same as any cause for inflammation of the pituitary gland. And basically what we are looking for is thickening of the infundibulum. The pituitary gland may or may not be enlarged. In this case, sagittal T1 weighted image here shows thickening of the infundibulum. If we remember that the infundibular recess should be very thin, we can see that there is extra tissue in there. And also the pituitary gland is enlarged. Intense enhancement, and most patients will lose the posterior pituitary bright spot, as we should be able to see on the pre-contrast T1 weighted images, but some of them may still have preservation of the posterior pituitary. So very non-specific finding, and if subtle, you may not be able to detect it unless you have comparison with prior imaging. This is a case of a patient with melanoma who was placed on ipilimumab, and you can see 6 weeks later the patient presented with hypopituitarism, and you see that the pituitary gland has become larger, the infundibulum is thicker in this patient who developed hypophysitis related to ipilimumab. The drug was discontinued, the patient was placed on steroids, and the size of the pituitary gland decreased, and as well as the enhancement, and also the infundibulum decreased, although not entirely back to baseline. But these are important cases to recognize. Usually this is going to be known clinically because of the panhypopituitarism, but this can be lethal if not treated promptly. Finally, we're going to discuss briefly Langerhans cell histiocytosis. This is one of those diseases that can occur anywhere. It is rare. It's usually a disease of children, young children with less than 3 years of age. The typical location is in the bones and calvarium with these well-circumscribed lucent lesions that have beveled edges, but they can occur anywhere. You can have solid masses, you can have parenchymal masses, intra or extraaxial masses. This is a disease that is known to be a proliferation of dendritic cells. It originally was thought that these cells were the same as the Langerhans cell in the skin, but now they have been shown to be different. And now there is a body of research that favors this being a sort of inflammatory neoplastic process that occurs. And therefore you have this enhancing inflammatory tissue that can grow in basically any area of the body. When it occurs in the central nervous system, most patients are going to have involvement of the infundibulum and hypothalamus, as we can see in this case. Enhancement is very avid. Rarely you can have involvement of other areas other than the infundibulum. You can have involvement of the brainstem, cerebellum. Sometimes you can have enhancing masses in the choroid plexuses. And one of the described appearances on MRI of Langerhans cell histiocytosis is that it can look very dark on T2-weighted images. Remember that we talked about neurosarcoidosis being dark on T2-weighted images. Other granulomatous processes can be dark in their areas of enhancement. Tuberculosis, being a granulomatous process, is also dark in certain stages of the granuloma. And Langerhans cell histiocytosis has been described to produce profound T2 hypointensity in the enhancing masses. But the appearance can be the same, exactly the same as hypophysitis. In this case, there is much more mass-like enhancement, but cases can be much more subtle. And the characteristic clinical appearance will be that of diabetes insipidus. And patients will also lose the posterior pituitary bright spot. And with this, I conclude the final part of the talk.